Yeah.
Okay, all right. Well, I'll tell you a little bit about what we've done at CU in Denver, and a little bit about strategizing for how I think this needs to be served up to emergency medicine people. And I would love this to be a roundtable brainstorming session. Maybe we'll have some more people to migrate. There's a disclaimer. How are things going? I don't need to know. Well, I'm not as concerned with this group, as to what you're going to come away with, but what kind of problems are you seeing, and what kind of strategies are you using to help people understand end-of-life stuff in the ER?
I think the biggest issue we have is that people oncologists don't seem to address the issue. They're fairly advanced.
Oncologists, yes.
In treatment, and it's frustrating as the emergency physician meeting somebody for the first time, saying, "Oh, you have this." I was telling Maureen the other day we had an ALS patient who was already wheelchair bound, could only speak, who ended up getting intubated because nobody had addressed. Yeah.
Nobody knew that this was okay. Oh, is it on? She's just a gentle folk in her talking. Come on and welcome. We're having a small round table.
That is fantastic. I'm going to be trying to run 2 rooms at once, so I'm going to check in with you guys and see is there anything you guys need before I bounce over to the post. I'll be back in though.
Okay.
Emily was here as well.
Yeah, I think she's not going to another. Yeah, we're playing juggling here, so
Right.
sorry to interrupt you guys, but
No, that's
you guys
fine.
got everything you need.
Yep.
Check back in if anything
Sounds
comes up
good.
for you. Take care. Thank you.
Maureen, remind me where you are. Southern California?
No, I was at NYU. Now I'm at Rutgers.
Oh, okay.
The other side.
That's right. That's right. Yes. And tell me what struggles you guys are working with.
So, a few things. First of all, I think there's health literacy, so that patients don't really understand what you're telling them. They don't hear what you're saying.
Right.
So having the facility to be able to address that. The other thing is we have a high bilingual population, limited translators or interpreters available to help, with that. And I think that the whole idea of whose job it is,
Sort of like you're talking about, Moira.
is how difficult, that is in the ED. So whether or not it should be the physician, should it be a social worker, should it be, care management, should we have palliative care come down for these patients?
So it's mostly initiating advanced directives that you're doing. Are you seeing any that are coming in with advanced directives? You're doing the groundwork. Very few.
Very few.
Okay.
Yeah.
Is that true for you, Eric, too?
We see more. Certainly more now than we did before. We're a POLST state, and so we have,
It almost used to be a medical aid and dying state. We won't go into that this week. This week you are.
Yeah.
But you're a POLST state, right?
And so I think our challenges are people are still uncomfortable with what if they change their mind? Is this really permanent? What do I do with this information? And working in a busy county hospital, people are feeling overwhelmed, and the perception is I don't have time to deal with this. Even if I want to deal with this, I don't have time to deal with this.
Yeah. That about sums it up. So what I wanted to do was talk a little I work a lot in the community, actually, these days, educating. Come on and join us. What's this? We're doing advanced directives, end-of-life conversations. This is F. Okay, that's all right. So I thought I'd fill you in, and this may be just preaching to the choir, about where the scope of advanced care planning is doing nationally and where it's headed and what best practices are, and then talk a little about the ED and our role as ED leadership in terms of thinking about what we're going to do. This is one of my favorite slides. This is a survey from the New York Times that happened a couple of years ago, in which they asked people how they wanted to die, and 88% of them want to die suddenly. There's 3% who don't want to die at all, don't realize that we're mortal people.
What that might mean.
There are 1% who want to die having sex and being shot by a jealous spouse, but it's a great little survey. I love it.
Is that a fill in the blank, like a write-in?
Right.
You know, and the New York Times Magazine has this little graph thing, the survey that they do every. Anyway, I use it a lot in public just to remind people that although 88% of us may want to die suddenly, currently only about 10% of us die abruptly. Abruptly, not in an ER sense, but within days, weeks. And the other 30 are the trajectories of terminal cancer, which is the 6 months trajectory. This is Lunny's graphs from 2003. And the basis for hospice, which is the funding for that. What we see, I think, in the ER, usually this organ failure trajectory, where people never get better than they were before the downset. But I think families tend to be really shocked the one time that we don't rescue somebody from the COPD exacerbation or the heart failure exacerbation or what. And then 30% of people, 30% of people dying with frailty, dementia, et cetera, that we see. What Bailey calls the subtacular deaths, which is, I think, such a wonderful term that she uses. I think she's British, isn't she? Is she? They have such a way with words that it's wonderful. So we rarely die suddenly. I think one of the takeaways from Gawanda's book, Being Mortal, was that the medical care system focuses on safety and survival rather than quality, even if it cuts things short. And every public survey that I've seen talks about the fact that there remains a 10 to 15% of people who say quantity is more important than quality. And that's going to remain. And I round with ethics in the ICU, and the moral distress of the people who stay up in the ICU, who are what the providers would think is a futile life or a futile care, really they struggle with it. I don't think we do as much in the ER. We have the advantage of the fog that says, I'm not sure what's going on. But for most people, certainly living until they die is their goal. This is another graph that The Economist took out of JAMA online a couple of years ago, which the point of which is just to say we are extremely diverse in terms of what would be worse than death and what would not be worse than death. So half of people say that if they were incontinent, this was a survey actually of ill 80-plus-year-olds in the hospital. So this is not the hypothetical abstract ones. But half of them said that if they were bowel and bladder incontinent, that would be worse than death. The middle line here is just equal to death. But half of people say that would be okay. Relying on a breathing machine, on a ventilator, half of people say that would be worse than death, but almost half of people say that would be better. And I spend a lot of time reminding the residents that we can't judge quality of life, that we have to have the dialogue with families and patients, because we vary. We're a very diverse society. So.
Interesting that bowel and bladder incontinence is considered worse than being on a ventilator.
Yeah, yeah, right. Can't get out of bed. Bedbound, half of people say no way. Half of people say that would be okay. So you guys all know Bud Hammis and his work with advanced care planning. So he's a family medicine guy up in La Crosse, Wisconsin, who for 30 years has been trying to figure out how to get advanced care planning woven into the community of La Crosse, Wisconsin. He managed to get Mayo's to talk to Gunderson, so that was a miracle. He does have a very homogeneous white community up in Wisconsin. And over 30 years, he's developed a sort of best practices, which has started to be adopted on the Medicare billing sheet. The scripts follow early, middle, and late stage. His package deal to do advanced care planning, I know, has been bought by Kaiser in our state. You have a lot of it, penetration.
I know it by a different name.
Okay, what is, tell me.
What, I don't remember what it's called.
But
Kaiser,
respecting choices are on,
choices,
right,
yes,
yes,
respecting
okay.
choices.
Yeah.
And so interestingly, Kaiser bought it, but they're not using it anymore.
I've heard rumors.
They've now gone to Vital Talk training.
Ah, good. That's interesting. So they're doing it more, you're going to have to teach me a little more about Vital Talk. I've been on the website and I've heard some talks in past years. But is that a structured kind of first steps, middle steps, late steps kind of thing or not?
I would say that it's not, it is not, this is the order that you must follow things. I think the fundamental philosophy of Vital Talk is that by dealing with emotion, you have to deal with emotions first before you can deal with the cognitive stuff.
Okay.
And so it teaches you methods to deal with emotion, acknowledge emotion, and look at emotion as data that you can then use to move on to your cognitive discussions like advanced care planning.
Gotcha.
And it's sort of, it's really more about how to steer the conversation and how to transition the conversation.
Right, and make it acceptable to talk about it by not
Yes.
marginalizing the emotional thing.
Yeah.
Okay, so
Yeah.
so Hammas's thing is that there are early steps that everybody who is of age, whether that's 1850 or whatever, that everybody needs a medical durable power of attorney, and they need to hypothesize, maybe practice, start thinking about what would happen if you ran your mountain bike into a tree or skied into a tree well or whatever. And think about the kinds of things that are important to you. This is sort of where the public is coming from, and it actually does relate back, I think, to the ER. And then are there some religious things that your provider should know that would inform, are you a Christian Scientist, whatever. And then middle stages being, oh, I've got a significant illness, maybe it's not life-ending right now, but let's think a little more seriously about what you want the next time you're admitted to the hospital. Do you still want to be intubated for your COPD flares, et cetera, as well as making sure that you have an MDPOA and that you've talked to your family. And then last steps being the POLST paradigm, where you translate those wishes into orders during the last 6 to 12 months of life. Okay. Now, the POLST form is being abused. I don't know whether it's being abused in New Jersey and California, but it sure is in Colorado. It's being handed to 65-year-olds. It's being required in nursing homes, which the POLST national people say, please, please don't make it required.
It's supposed to be in the last 6 to 12 months.
Yes.
Pennsylvania's a POLST state, and people just walk in with
Yep, they do. Yep,
That's right.
they walk in with it. We had one ethics consult on a 33-year-old who was having ovarian surgery and printed out her MOST form and took it to her doc and said, I don't want to have a CPR. It's like the doc called us to say, what the hell do we do with this? Anyway, so this is sort of what Hammas has done. And I think in general, it's going to be interesting to see how Vital Talk merges with that, or whether there are just different ways of doing it. I think in general, I know at Kaiser in Colorado, there are communications people who sit in for the people at the docs at the bottom of the bell-shaped satisfaction curve and sort of try to engage them on a nonverbal and emotional level to notice what's going on with their patients. So, yeah, we'll see. Anyway, so I think it's important in the ER to lead actively and to understand by doing your own advanced care planning. So I'll do it even to you guys, which is, do you guys have any forms? What do you have?
I have a power of attorney.
Okay.
Advance
And?
Directive and Power of Attorney.
Okay.
I'll tell you an interesting story.
Okay, no. So What has been being pushed right now is not so much, it's a narrative I didn't intend. We all have narratives that we don't intend. Is the MDPOA, the power of attorney, for medical care.
Medical care.
Yes, they're different. And the values inventory and some conversations with your family. I actually am not a proponent of CPR directives or living wills particularly, but tell me your story.
So my story is that in 2014, my wife and I redid our whole estate planning and went through this long process of talking about, you know, our values and what we would want, et cetera. And you know, I had said, you know, if I was in a state where I was irreversible, not, you know, I don't want to be on a ventilator for a long time. And in April of 2014, I got necrotizing fasciitis. And so
changes your perspective, brings it to the edge of the abyss.
And this was just after we had finished all this stuff. And so, not surprisingly, after the second surgery, I came back to the ICU, intubated on pressors, and my wife's like, "What do I do? He told me he didn't want to be on a ventilator." So this is, I mean, she's not a physician. She's a very smart person, master's degree. We had long conversations, and she still didn't totally understand the reversibility, irreversibility. She just saw he's on a ventilator. Oh my God, is this what he was talking about?
Yeah.
Luckily, fortunately, you know.
Well, and this, I think, is one of the problems with written advance directives, and I actually spend a fair amount of time in the community talking about, you need an MDPOA, they need to know what's important to you. But the rest of it, number one, the living will rarely applies. What's terminal state is debated hotly, and my neurologists tell me that persistent vegetative state is just not, is an obsolete term these days. So those are the only two times when the living will kicks in, and the CPR directive, whatever, if people are passionate. And I sort of look at them and I say, when they're 40, so if you have a bleeding ulcer and somebody sticks a scope down your esophagus and you Brady down to 0, because I get vagal easily, you don't want them to resuscitate you, give it a break. That's something for later on. Anyway, it's very interesting because I think we all lean to having scripts that we can, recipes that we can follow. So a lot of people are going to start coming in as they get educated in the community, not as much with written advance directives until near the end of life, but I think they're going to come in hopefully with an advocate who knows what their values are. We use the Conversation Project. Do you guys use that at all, or what do you guys use? Do you know?
I've used it with my family.
Uh-huh. How do you like it?
It was pretty good. I mean, I think it was a good start. And
It's a start.
Yeah.
So this was invented by Ellen Goodman and a group of people in Boston, and we use it in the community for early advanced care planning. There's other ones. Prepare for Your Care, I think, is wonderful, which is one that comes out of your shop, and is an online way. And in the bibliography that's part of this program, all those links are there. But I like Prepare for Your Care. Get Your Shit Together is another site. There's another one. Yeah, it is. So
I used this at my Jewish center, and we had over 200 people who came with, you know, it was kind of paired. So,
Nice.
And it was really wonderful.
we've done some in the, good. It starts the conversation, as you say. It's not the end-all and be-all. When I usually do it, I look, so there's a what matters most to you, which we all know will change over time. And then there are these Likert scales, and you have to teach people that the Likert scales, 1 is not better than 5 or vice versa, et cetera. And I usually ask my audiences, for instance, what are your concerns about treatment? Are you worried that you won't get enough care, or are you worried that you'll get overly aggressive care? How do you find your audience responds to that, Maureen? Or do you ever do a survey?
Haven't
with
done
them?
a survey.
With them? Yeah.
Yeah, so
We usually do a hand-raising thing. I live in Boulder. It's an entitled control freak kind of town. And so everybody raises their hand to say they're worried that they're going to get too aggressive care. But I think we've probably all seen in our hospital population people who are afraid they won't get as much care. And so reminding people that it cuts both ways is sort of useful. So what are you seeing? We've already talked a little about what you're seeing in the ER. Moving on to that with advanced directives and POLST documents. When you do get them, you get them, you don't get them.
So I can speak from two places. So
Okay.
The culture at NYU is totally different than the culture at Rutgers. So Rutgers, no one has anything. At NYU, everyone has everything. So
Oh, really?
they come in with their documents, yeah. So it's just, it's also a different patient population. And so when you talk about fear of overly aggressive versus fear of under resuscitation, you definitely see the two play out in both places.
Yeah.
Rutgers, there's a lot of mistrust. So it's
Yeah, they're
interesting.
afraid that they are going to be marginalized, and they probably have a good reason historically to be worried about that. We had a consult a few years ago, a Hispanic guy who was the patriarch of his family, big stroke, still in the neuro ICU a month later, and the team was laughing at him because one of his sons looked at the team as they were trying to suggest that, maybe this was the end, said, if we had more money, he'd get a brain transplant. And it was a pure, honest expression of concern, vulnerability. Of course, they laughed at him because nobody does that. But, you had to lower the heat in the room and realize that for them, they were just sure that they were getting care, that they would be different.
Yeah.
You see other stuff with POLST forms and advanced directives?
I would say we, if you compare the county hospital to the university hospital, not surprisingly, the university hospital has
more
many
written
people have
documents.
more written documents. And so the people who come in with POLSTs at the county hospital, most of the time they're filled out correctly, and they tend to want to emphasize comfort care or less aggressive care. But we have a diverse population as well with a lot of different cultural differences, and so we also see, I'm also on the ethics committee, and we see similar moral distress and certain cultures that stereotypically want more care or are feeling marginalized or vulnerable and so are defensive from the beginning.
Yeah. Myra, have you had much experience with them?
Yeah, we do get a fair number of patients coming in with POLST forms. Not usually filled out correctly, unfortunately, so that kind of puts you...
Yeah, we'll look at some of that data here, yeah.
And then another issue we had is that we had a fairly aggressive trauma surgeon who the patient would still be in the trauma bay and she was filling out the POLST form for them. So that, and then they would keep the form with them, and then when they came back subsequent times, they still had this form, but it was obviously in a different state of...
in a different condition, yeah,
lying there
yeah,
with 3 gunshots.
yeah.
So they were trying to deal with the...
Yeah, it's interesting. I think the POLST form has been a step forward, translating wishes into direct orders, but docs just don't understand them. And so I've seen a lot, and I of course see the problem ones because I'm on the ethics committee, and so we get consulted on the ones that don't make sense, but we'll look at some of the data on it. Of course, one of the problems with honoring them, and I get a lot of complaints about them, is that we're fast-paced. We have no history with the patient. Oftentimes, we can't find the forms. How is your electronic medical record in terms of finding them there? 0, yes.
We
Ours
actually
too.
have at the top bar, right with the vital signs, there's actually an advanced directives.
Is there?
Yeah, so you
We've
can
got
click
one through Epic in ours, right? It's still just forms. It's not intent. It's not values. It's, yeah, right. But, so I think that I call it the fog of the ER. We don't know exactly what's going on. We're a little nervous about who's the proper surrogate, because oftentimes the person who comes in with them is not who they would necessarily authorize. And we do have this reflex, and certainly our residents have this, which is to save lives. So here's a patient from a couple of years ago, 65-year-old with COPD. 2 years prior, she was hospitalized with acute exacerbation, intubated, had like 2 weeks on the ventilator before she could get weaned, so did written advance directives during her recovery. And I think that's a very teachable moment for advance directives up on the floor, and no tubes in the future. Comes in with a PCO2 of 70, somnolent. Her daughter is her agent, and she's consulted, and the question is, at this point, do you intubate her, or do you support her comfort and her dyspnea? I think that's not an uncommon thing that we see. In this particular case, Angie was pregnant with Karen's first child, and is due in 2 months. And so the question for Angie, of course, is, do I honor the do not intubate, or do I try to stabilize, knowing that all that she's talked about for the last few months is that she's getting her first grandkid? And I think that just sort of exemplifies the problem with advance directives themselves. If this were a POLST form, hopefully it would have been done more proximately as she was failing more acutely. But this is the hooker that I think we have with advance directives. So in general, the living will and the CPR directives show preferences only. They aren't orders. They're directions for future, and we are not very good at predicting that. They focus on treatments and check boxes. And I think Sidari is one of the ones who's highlighted the biggest problems with traditional advanced care planning, which are that we are really not good at predicting what we're going to want in the future. That we adapt in ways we would never expect ourselves to adapt. Aaron Ralston is sort of the poster child of that for me, the guy who had to cut off his arm in the Utah desert, who says it was one of the best things that ever happened because he always thought he was a loner and didn't care about anything, and he realized he had a community and a life ahead of him and all sorts of stuff. And we have a rehab hospital, Craig, near us, where we hear the same kind of thing from the quadriplegics, that it's like, oh my God, there is a life after quadriplegia, et cetera. And extrapolation, because when you check off the boxes, it's CPR and intubation, but then the question is dialysis or blood transfusions or antibiotics and all sorts of other stuff, and extrapolating from one of those is not very easy. So what's missing tends to be the context of the exact situation you find yourself in 10 years later, or the intent, or 2 months later. Or the intent, why are you saying that you don't want to be intubated, kind of thing. So the POLST paradigm started in Oregon. They actually withdrew last year. Did you hear from the National POLST Paradigm Network, because they didn't think that monies from healthcare industry should be used to fund the national program. And so they wanted to stay pure. But frankly, this is the map for currently. There are 4 non-conforming states, Nebraska, Massachusetts, Vermont, and Maryland. But the rest either have programs or are developing programs. I think yours isn't formalized. Oh, yours, Maureen, isn't quite formalized. It's in progress. Is that right, in New Jersey? And you're Pennsylvania, which is a pretty full on state. And you really got a good one in California. So they put out an interesting policy in April of last year saying, hey, wait a minute, let's use this appropriately because it's getting screwed up, sort of in the ways that we've been talking about. So the advantages for us are that those are actionable doctor's orders based on current condition. So that's the difference with the advanced directives, Myra, which is that in the future, predicting what you're going to want versus, no, this is based on my condition right now. I'm within 6 to 12 months of dying. and this is what I'm going to want, knowing the arc of my exit. And it's to be honored across sites. So the DNR, my docs still don't understand when you write a DNR in the hospital that then that expires at the end of that admission. You could certainly use it as a conversation point, but it has to be translated either into a CPR directive or into a POLST form. Can be done with surrogates and revised. Copies are acceptable, and the electronic registry. Does anybody else have an electronic registry besides Oregon?
New York.
Do they?
Yeah.
Okay. Yeah, which is really helpful for EMS because then they can cross-check and see. And last I heard, and the data that I'll show you is actually 30,000 people in the registry in Oregon, which is pretty cool. So here was a patient we had this past year. EMS started CPR on an 87-year-old brought in from his nursing home. Short response time. The nursing home has faxed you his POLST form, which says no CPR. They arrived doing CPR. And I think my residents struggle with this. Do yours? But CPR is in progress. Or even worse, the patient's been intubated.
Well, I think we struggle. I hope we struggle with it.
Okay.
Because it's not an easy
Okay.
decision.
That's honestly said, yeah.
So, you know, I feel like our residents are willing to move forward with the appropriate action, depending on what you think that is. But it's still I think it weighs on them. This is a big decision.
Mm-hmm.
So I think that in this particular case, the difficulty is that they called EMS to the nursing home where they already had the documentation which said no CPR. And so that's really where the tension is. If they knew that they didn't want CPR done, why are they calling EMS? So, you know, had this have come from the home, you know, like, okay, maybe they just didn't understand what that meant or, you know, or whatever. But I think that the nursing home brings a lot of ambiguity to what the decisions, you know, are. And I think that's where everybody has, you know, the problem. It's not so much that this is what the form says and this is what the patient wanted, but why suddenly is there a discrepancy between the form and what's being done now?
See, it's interesting to me that you make a distinction between the home and the nursing home, because to me the motivations are different, but it's the same. Like the nursing home doesn't want people to die in the nursing home because it affects their
I think it's the same thing with
ratings.
the residents, like it's that whole of somebody's going to die, and I don't want that to happen.
Yeah, on my watch.
So for home, it's more a matter of fear. You know, like we kind of put it in that context. It's like, okay, really, you know. But nursing homes should, you know.
Having dealt with this with my own families, I know that the skill level in the nursing homes, even if they have initials after their name, is such that I think they're as frightened as the people in a residence. And it's extremely variable. And so when they get frightened and it's out of their hands, they dial 911. Hi. Still doing okay. Well, come on.
That scenario. I've resuscitated many no codes, unfortunately.
And
Because often actually they don't have the paperwork available.
yeah, that's true. And there's always, I guess, one of my take-homes for my residents is there will always be a gap between patient wishes and what we do in the ER. But it is our obligation to try to narrow that gap when we can. Yeah. And the other thing is that I think we need to understand that ethically it is as valid to withdraw treatments once they're started as it is to withhold them. And in fact, ethically, it's probably oftentimes superior to withdraw it because we don't know when we start. But you're absolutely right. The burden and the ambiguity and the complexity of doing that and what it feels like psychologically for us to withdraw something or for the family to say, let's take the tube out, is very different than not having put it in. And there's starting to be some legal cases that actually refer to this that Thad Pope has started to write about in terms of suits from families who say, wait a minute, once I got to the point where you'd intubated them, even though you weren't supposed to, you idiots, I can't withdraw And there's a couple of cases where the CPR has worked despite a no CPR order, and the patient has gone on to live bedridden, whatever, vegetative for a couple of years, and people have won a lot of money now saying, you owe me the money for caring for my loved one. Or it takes 10 days before I can get my head wrapped around the fact that, yes, we should extubate now that you intubated against my will. And those are starting to come out. So some of them do not involve, most of them do not involve the ER. I think we're probably more thoughtful about it than other people, either EMS or the surgeons in-house or whatever. But it's becoming more of a problem, and in this rights-based society, it's going to become more of a problem as people want to sue. So this is the 2x3 that I really like that Schmidt and the others up in Oregon did, which looks at the POLST. Section A of the POLST is, do you want CPR, yes or no? Interestingly enough, a third of people in their registry said, yes, I do want CPR as part of their POLST, okay? And then the three general categories of comfort care, limited or selective care, or full court press as part B. Do you guys have about the same thing? That's sort of the generic, sort of most POLST forms are, show something like that. So we're much more comfortable with comfort care and no CPR, or full care and CPR. But interestingly enough, that accounts for only 60% of the POLST forms. So the others have something else going on. Now, this CPR but only comfort care, Oregon has stopped accepting in the registry that they do. They say that's incompatible. Not incompatible with life, but incompatible requests for the ER or EMS to do. The big one that we struggle with, and I've seen a lot of complaints from people, both in the literature in the ER and from my colleagues, is this 30% of people who say, no, I don't want CPR, but I do want some care, selective care. And thoughts about that? It makes a whole lot of sense, but ER folks whine about it, you know.
Well, right.
And well, not only ER folks, but others do. It does make sense. The other one that people have a hard time with is, I want CPR but only limited care. And Terry Schmidt says, she thinks, as she's talked with people about that, it's that, yeah, if I arrest in front of you and you can shock me and get me back, that's fine. But if I end up having to have drips and a tube, that I don't want. Which actually makes sense to me too, even though we look at it and go, well, doesn't help me.
I think it goes back to your point as far as context and
yes.
understanding that, and it's so difficult to do that in an
right.
individual basis.
Yeah, if you just put in a central line and nailed the right ventricle and hit something that caused them to, you know, Brady arrest, that's different than if this is the circle on down from a sepsis kind of thing. So the evidence is that the most direct or consistent effect of the POLST form is on CPR directives. 30% of people in Oregon have a POLST as of, that's now 7 years ago. And so CPR directives are the things that people look for most and that I think are most helpful to us. If you've got a CPR directive that says no, I think we should feel comfortable withdrawing or not doing CPR. And in their series, if you had a comfort care directive on your POLST form, only 6% of people died in the hospital versus 44%. So it really does decrease the number of people who end up at their last breath being in the hospital. And that's probably a significant thing. Now, Clemency in New York, he was from Buffalo, so he's not somebody who you would know at NYU. But he had a study last year in which he looked at a series of 100 consecutive POLST forms And he was not happy with the inconsistency and the problems and the gaps. Half of them were filled out by the patient, half by a surrogate. That's perfectly fine. 100% had yes/no CPR, and 82% had intubation instructions. But he was unhappy, and his group was unhappy because 2/3 of them had at least one blank section, which is not necessarily a bad thing. 56 forms had only some treatment guidelines and nothing else that clarified what those meant. And they felt that 14 of the 100 had contradictory treatment orders, some of those being those things that we've already talked about, that are those in-between things that frankly are okay. We just have to think about it. The other concerns that have been expressed about the POLST in studies recently are 3/4 of the forms being filled out by nurses, particularly in hospice and in nursing homes. Now, you could call that good, nurses or social workers. You could call that good because they probably have more time and better communication skills than some of us. So that could be good, but when the doc signs it, sort of like Radar giving it to, what's his name, there is a lack of sort of insight, and these things are only as good as the conversation that happens, which is why Vital Talk is so important. There's very few studies on the quality. Clemency's was one of them. Although the POLST paradigm people say you cannot mandate this in assisted living and nursing homes, a lot of them shove it to you the first time you're admitted there and say you've got to do something, which then becomes probably a very poor quality form. And quality variability is being seen, just starting to be written about across the states. I have heard several EMS systems who say we just will never honor the POLST form. It's too murky, we can't sort it out, no. And when I present that in the community, people say, how the hell do I get my wishes honored? This is where we're at, so.
Is that in a state where they're giving EMS training?
I've heard it in several states, and certainly in mine. They're getting training. Go ahead.
For providers to keep their licenses on the EMS side, or a licensed state, they must go through post-training.
Awesome. I like that.
So
what else are you guys doing? Yeah.
That would be like illegal here.
Yeah, I wonder
Well,
about the private, a private EMS group as opposed to, one of the
A state one or a city one,
Yeah.
I don't know.
Municipal-based versus private
Yeah.
systems.
And Marachi has certainly reinforced the fact that we like those extremes. We're not very comfortable with how to interpret the others.
I just have a question.
Yeah.
So on the form, it's supposed to be updated, I think, every 3 months.
Oh, really?
Or something, yeah.
Ours
So
just says whenever.
Oh, so in New York.
Oh, really?
Yeah, that's
a
part of
tyranny.
it. So that's why I'm curious if you're not aware of that, whether or
No.
not they're
It's
not
actually
Whoa.
updated.
That is a
Yeah.
total tyranny
It's
because
dated,
that's
but
expensive.
it's not.
Yeah, it's dated, and then ours has several lines for renewed, or then you tear it up if you want to do a new one, kind of thing. Wow.
Yeah,
That-
maybe it's
that is
just
a burden.
I think that it's supposed to be
Wow.
renewed in a certain time period to make it valid.
So, talking about solutions rather than whining, I think that in the ED we need to take the leadership in saying, this is problematic. We will always over-resuscitate. But we've really got to be committed to closing the gap between people's wishes and how we care for them. I also think we need to stop marginalizing end-of-life patients because they will call 911. Sometimes it's the nursing home, oftentimes it's the residents. And we're never going to, we never should, I don't think, want to tell them not to call 911. If they're out of their league, we're the experts, and so is EMS. So I think that in the first emergent minutes, the MDPOA is important, but the POLST forms about CPR and intubation really help. In the first 5 minutes, you'll look and you see and you honor that. There are times when we can consider less invasive ways of stabilizing people. And then I think the documents provide great props for then going and sitting in with the surrogate or the patient and saying, so I see you've thought about this. And then starting the conversation. And that's where you guys come in. And I really think we're not very good at asking and starting that conversation before you go down the critical care route. My current pet peeve is sepsis, because we get a lot of 96-year-old people who come in with sepsis, and before you can take a deep breath, they're intubated, and they've got their A-line, and they've got everything else, and it's like, whoa, you can take, I mean, we all know that fluids and early antibiotics is probably the thing that really makes the difference, and not all that, but you know, you start down the protocol, and they're in the ICU before the conversation has ever happened. I do like that resuscitation pause thing that Marachi has been proposing. To be asked to ask after the first 5 minutes, be clear about, as clear as you can be, about whether things are terminal or treatable, and then look at the arc of the prognosis and design a plan that includes the words time trial or next steps, and help people understand a narrative that says that we can always withdraw. We have to set the normalization for people that it's okay to withdraw stuff, because they do feel guilty and we feel guilty, and I think our language can make a difference. I don't know whether that specifically comes up in Vital Talk or not.
In terms
of normalizing some people in this situation would, some people would do that. We are committed to honoring the fact that they didn't want to be intubated. Here's why it happened. Helping them craft that narrative.
It's part of make a recommendation.
It is.
You know, based upon what I know
Right.
about you now, I would
Okay,
recommend.
what I know about you now. And I think that's the thing in the ER that's most important, is the dust sometimes settles in the ER. Sometimes it doesn't settle for 5 days. But when you know that, acknowledging it and taking charge and ownership of the fact that this is no big deal. We understand that sometimes we have to withdraw because we know we over-resuscitate. Setting that narrative so that people have a story that's not a chaos story when they leave a death. So, yeah.
I was just going over the MOLST form for New York, so I didn't want to give misinformation. So it's review and renewal. It doesn't specify a time. It just says the patient moves from one location to another, major change in health status, if patient or the decision maker changes his mind.
Yeah, okay, phew.
I thought it had to be done within a certain
because that would be a
time
tyranny.
period. Yeah.
And then I just have advance directives trigger a conversation. This is the way I work on it with my residents. I'm not here to preach to the choir. But you have to remind people that patients have a right to refuse even life-sustaining treatment. I think we've mostly got our head around that one right now. But we aren't good at judging quality of life. We've got to have a conversation. And even understanding comfort care takes a conversation. My mother-in-law with progressive frailty and an aphasic stroke 6 months before fell in her assisted living, busted 5 ribs, got a 1.5 liter hemothorax, was clearly on comfort care, and even her 2 ER doc kids sat there going, what does comfort care mean for her? Does it mean a chest tube? Does it mean admitting to the hospital? I mean, we struggled with that. So this takes conversations and times. So ACEP does have a policy statement on POLST that describes the choices and describes how people are legally protected, and either explicitly through statutory actions in each state or by common law, and Art Dursey has been very good at articulating that. And then you guys are you going to do an EM talk? Are you going to do a variation? Is that what you're going to do?
That's what it is.
Very cool.
It is a variation of Vital Talk.
Uh-huh. Are you going to publish it, trademark it, modulize it, whatever?
It is. So it's using the Vital Talk tools, which were already trademarked.
Yeah.
And it's trying to kind of take the principles and apply them to emergency medicine, because the paradigm in Vital Talk is in the morning we're going to do the first conversation.
Right.
In the afternoon,
Yes.
we're going to do the follow-up conversation.
Right.
No, we just
More
have
on the
one conversation.
palliative care. Yeah.
And so we're sort of trying to change the case scenarios to be more applicable to emergency medicine and recognize that emergency physicians need to sort of you need to get to a destination a little bit faster.
A little bit.
Yeah.
You said that very nicely, Eric. And so then I like trying to teach the residents to embrace subtacular deaths in the ED. We've used the serious illness conversation. You said there's some glitches with merging that with Vital Talk or whatever.
We just learned that,
It's
I
over.
think.
It's over?
They're divorced.
The divorce.
Which is really a shame, because the conversation guide has the content,
Yeah,
and Vital Talk is sort of the method to get there.
Right.
To me, it would have been
a nice
perfect
marriage.
But I think
Did Gowanda?
I don't really know the details, but my speculation is dollars got in the way or style got in the way.
Well, right, Ariadne Labs was, yeah, okay. So, and then I think the leadership in the ER needs to say, what is your position? If they have a POLST form, why are they here, is one thing I hear. If I'm here to save lives, this I heard in the last year. If I do save them, they can sort it out in the ICU. And there's nothing more we can do for her. And that's sort of one stance of ERs that I see. And the other is, help the hospice patient and the hospice team. It's an appropriate role in the ER. We need to be careful whether we admit somebody or not. But hospice patients can be in the ER, and we can be the pivot point, both for the symptom management and the dispo. I think that's the other thing that the POLST helps with is dispo. Does this patient want to go into the hospital? Do they want to go to the ICU? So CPR, intubation, and disposition seem to be the best ways to help people. So we do important things. I'm going to just flip through this because I do want to. There was just an article this month about the things that we need to do with the health record, electronic health record. There was a consensus thing. It's in the references in the handout that they have online. But what the problems are with the electronic health record, which I think we all know well, but that it's an opportunity that perhaps we could get better at. And then I'm going to just, so I think the other thing to suggest to our people is disregarding patient preferences as a medical error is starting to be more of a problem. Allison and Sidora wrote this particular editorial. And then Pope last year started to review disregarding advance directives and DNR orders in some of the cases that are kicking around. And actually it got picked up by the New York Times, and Paula Spann did a lay thing about it. I think that's where we're going. It's the will of the patient, not the provider that controls. Institutions can be fined. They can't claim immunity. I didn't know if they knew. I think the ER oftentimes gets away with that. And one of the quotes that has from one of the judges is, unless healthcare providers face consequences for ignoring or failing to follow a patient's directives, the public policy favoring these directives stands to be undermined. So, all right. That's the way you play doctor in this century. Thoughts, comments? Okay.
Nice.
Well, your part is more important, actually, than the documents, which is what I keep harping on, is that you know, short of the resuscitation time in the ER, you got to talk to people. And it's going to be really great to see a collapsed form of conversation. How do you, in 5 minutes, establish trust and figure out at least what the next steps are going to be that are most aligned? So go for it. So are you going to, do you have a task force? What are you going to do?
So Karita Grutzen is working on
She's done a lot of good work.
bringing EM talks to, I think, 40 different sites. I think, though, the whole idea of whether or not it should be called EM Talk or how we're going to continue along those lines as far as...
So you have your module created, and how long is it?
So...
That's a good question.
Oh, sorry. There's certain electric questions.
It's not, I don't think it's
We
defined.
most Vital Talk courses are like 2-day courses.
Yeah, right.
They do 1-day courses, and we just did the 4-hour course, which was right,
Worked.
which I think for emergency physicians you need to do that. We still need to tweak it a little bit to make it more effective in the 4 hours. It was tough to sort of.
This was your pilot run.
Well, we'd done it.
Last year was 8
hours.
last
We did
year
8
was
hours
8
last year, yeah.
hours,
So this
which
was a pilot for the 4 hours, and it still needs a little tweaking to make it as effective as it can be.
Thank you.
It was a good
Thank you,
conversation.
yeah.
Even if we still have problems, which is.
But we can solve them, so it's
Yes,
nice to have
exactly.
problems.
Yeah.
You know, it'd be